All right. And so just to let everyone know, today's session is going to be recorded. And next slide, please. Perfect. So I would like everyone to take a moment to go ahead and update their names on Zoom to include their full name and the name of your organization and your pronouns. Yes, we will all have very long names today, just so we can get to know one another better. And throughout this presentation, you guys can also go ahead and check the chat constantly, because we'll post relevant information there for everyone to review. And as we're waiting for everyone else to go ahead and join us right now, we're going to participate in a very brief icebreaker. So if everyone could visit the link that's going to pop up in their chat, it's native-land.ca. And what you're going to do is you're going to click on that link from your phone or your computer. You're going to go ahead and enter your location, and it'll let you know which Indigenous land you currently reside on. And so as we're waiting for participants to come join us, everyone can go ahead and click that link, native-land.ca. Go ahead and enter your location and share your results in the chat so we can get to know one another a little bit better. And once again, everyone can change their Zoom names to include the name of their organizations and their pronouns. And we can go to the next slide. All right, so this TA session number 2 is being brought to you by HealthBegins and Aurrera with funding by the California Healthcare Foundation. Next slide, please. There is going to be a link to this entire presentation posted in the chat, so that way everyone can follow along with not only the information that's being provided on screen, but all of the additional resources that are also going to be included inside of this presentation. We have a lot of links that are going to be very beneficial to the learning process. And so all of those links will be inside of the presentation that we're posting inside of the chat. So today's agenda is for us to primarily cover credentialing information and resources, a few updates to DHCS coding guidance, and for us to discuss some budgeting considerations. Next slide, please. And now we'll go into some session background and objectives. Next slide. Perfect. And as I mentioned previously, we do have a link to this presentation in the chat so that way you can follow along. But today's primary objectives are for us to describe the process to becoming a credentialed CBO with an MCP, and for you all to understand updates to DHCS CalAIM coding guidance. Next slide. Perfect. So a lot of you have already joined us for previous TA sessions or for the statewide information session. And so as you all know, we are here today for us to be able to realize the promise of CalAIM by building out a new near-term and long-term TA infrastructure. We've already hosted these sessions in San Joaquin, Shasta, and Sonoma and Stanislaus. And today we're going to have on the line Partnership Health Plan of California to answer questions and provide credentialing information. Next slide, please. Perfect. Also, as previously discussed, we have 2 value propositions that we are presenting to you all today. One is geared for the CBOs directly, while the other is geared towards the managed care plans. And what we really want CBOs to understand is the value of the information that's coming out of these TA sessions. And alternatively, we want the MCPs themselves to be able to save administrative time by building better partnerships with those CBOs. Next slide. So that being said, we do have a few assumptions about the participants that are here in today's audience. And so those assumptions are that you represent CBOs that are in Sonoma and Shasta County, that you are at least at a high level familiar with CalAIM, and you are interested in partnering and building relationships with local MCPs in those locations. Next slide, please. All right, so we are going to go ahead and launch an audience poll on your screen that should be popping up. And as it pops up, I'll go ahead and voice over it. So the question is, as a CBO, what are your foremost infrastructure and capacity concerns as you move past the contracting process and begin refining, programming, workflows, and processes? What challenges are you anticipating? So Nasser is going to go ahead and launch that poll for you guys right now. Give us just one quick moment. And actually, Sorry, everyone. What I'm going to go ahead and do is just ask everyone if they could respond inside of the chat to that question. We have a few options that are on the screen right now, and those options are: you might not be sure because you haven't moved past the contracting process. You might have staffing or service capacity concerns. You might have accessing housing subsidies under ECM or CS, data sharing challenges, coordination with other local providers, billing and invoicing, securing an MPI, or other. If you have other concerns, go ahead and please share those in the chat. And so we have a few people that are also listing that they have multiple concerns, which is good for us to hear because we're going to have a full Q&A later on in the session, and we love to circle back around to these concerns so that way we can actually discuss them. All right, now give everyone else just a couple of moments to continue responding to that poll question, which is, as a CBO, what are your foremost infrastructure and capacity concerns? Perfect. I see more answers flowing in. Thank you all. All right, we can go to the next slide. Poll number 2. How far along are you in the CalAIM community support contracting process with an MCP? So we can go ahead and once again post those responses in the chat so that way we can circle back around to them when we have our plan, discuss some of the credentialing process. And some of our responses are: you haven't started or have decided against contracting, you've just started with an MCP, you're waiting for a contract, you're reviewing contracts, or you're in full-blown contract negotiations. And so you can go ahead and post those responses in the chat. And once we reach that Q&A, we'll go ahead and revisit some of those responses. Perfect. All right, and we can go to the next slide. So as previously mentioned, we do have Partnership Health Plan of California on the line. And I would like to go ahead and go to the next slide so I can let everyone know who is here with us that will be presenting and or providing a few responses to your Q&A questions. And I would invite them to unmute and say hello to the audience.
Hi, good afternoon. This is Amy Turnipseed from Partnership. I'm the Chief Strategy and Government Affairs Officer, and I will turn it over to Deb McAllister.
Hi, I'm Debbie McAllister. I'm the Associate Director of UM Strategies here at Partnership. Lisa.
Hi, I'm Lisa O'Connell. I'm the Senior Manager of Provider Network Education and Credentialing. Danielle.
Hi, good afternoon. My name is Danielle Biasotti, and I'm the Senior Program Manager in the Care Coordination Department at Partnership. And I'm helping lead the ECM benefit implementation and working very closely with Debbie and Lisa. Thank you. Pass it over to Annabelle.
Hi, everyone. My name is Annabelle Castro, and I'm a Project Manager here at Partnership.
Fantastic. Thank you all so much again for joining us today. As previously mentioned, we are here to make sure that CBOs have the information and guidance that they need to be able to, succeed in the credentialing process so that they can move forward with contracting. And with that being said, we can go to the next slide. We are going to receive a presentation on credentialing. Next slide, please. From the one and only Lisa O'Connell, who is a Senior Manager of Program Network Education and Credentialing at Partnership Health Plan.
Thank you, Alexis. Good afternoon, everybody. Next slide, please. So I'm going to walk you through from the beginning to and kind of through the process that it is right now. As many of you know, we do get updates from DHCS, so this can change at some point. But so if you are interested in becoming a provider, then you just email the CalAIM at partnership.org box for an assessment. You'll complete the assessment, turn it back in. The assessment's reviewed internally. And then the next step would be contracting. It has been approved by DHCS, our contract. We send that to providers along with some what we call startup documents, which is a 2-page document that asks for your tax ID, your group MPI, current business license, if it's applicable, if you have that, the current certificate of insurance, your W-9, and then if you're a new vendor to us or a new provider to us, we have a new vendor setup form if you're newly contracted. So once we receive all that and it's executed internally, we add it to the systems, and then that's pretty much complete. And then you'd be in the system after January 1st. The future for credentialing is that as we get information from the state and guidelines, we might start to credential the organization and those that have a pathway. So I'll go to the next slide. Oh, there you go. Thanks. So for providers, there is a pathway for some providers through Medi-Cal enrollment on DHCS. Those are doctors, nurse practitioners, PAs, LMFTs, LCSWs. We also credential other types of providers, substance use counselors, behavioral counselors, and we're waiting for DHCS in July to give us more information on community health workers. There might be a pathway through Medi-Cal for them to enroll and for us to credential. We just don't know yet. So then we would credential those if that's what we are told we need to do. And credentialing it's an application that people complete. It's longer if it's a MD or a PA. It's shorter if it's a substance use counselor with different requirements for certifications or training. We primary source the information. We check for the MPI, so they would have to have a individual MPI. We present it to a credentialing committee that meets once a month, and then they would be credentialed. If there's no pathway, which many of the providers for community supports currently, they might be volunteers or case managers or community health workers. There's currently no pathway, so we aren't credentialing those providers right now. Next slide. So when you start, we've had a lot of questions about MPIs. It is necessary to have a group MPI so that you can bill for services. And there is a step-by-step guide that's a link here that is an excellent guide, and I highly recommend everybody review it. It literally walks you through step-by-step on what to do and what taxonomy to register under, depending upon what kind of group you are. But it's very informational, and it's a great resource. The next link is a link to apply for an MPI. The DHCS Community Supports Information page has a lot of information. I'm sure a lot of you are very familiar with it. The PAVE website, when I talked about enrolling in Medi-Cal, PAVE is the portal for enrolling. That gives, if you wanted to go there, you can look and see what kind of organizations and what kind of providers have a pathway to enroll currently. It does change, as I mentioned before. And then the CalAIM information here at PHC, that's our webpage. We did some provider trainings earlier last week and this week. They're recorded. They'll be up later today, so you can access the recording and the information. We'll be adding FAQs that are updated in the weeks following. We're trying to collect a lot of the questions, update it, and then we'll be updating it periodically, but that's where a lot of our information lives. And that's all I have. So I'm sure you might have questions, but.
Thank you so much, Lisa. So we are going to ask everyone to think through their questions because we're going to have a Q&A very briefly. And I would also like to flag that we are going to provide a little bit more information about the MPI process that Lisa just entailed. But for now, we are going to go ahead and discuss some of the updates to the DHCS guidance pertaining to coding. Next slide, please. And for that, we'll hear from Danielle and Debbie from Partnership Health Plan.
Hi, everyone. So we wanted to give you a high-level overview of the DHCS Enhanced Care Management and Community Supports coding as they released an updated coding guidance in November. And we'll put the link into the chat for the updated link for the coding. For ECM, there are 8 specific codes, and the ECM provider will bill those applicable ECM codes with the modifiers where applicable for reporting purposes. And PHC will pay the ECM provider on a per enrollee per month basis. The amount will be $350 per enrollee member, and an ECM or Enhanced Care Management Treatment Authorization Request, or TAR, must be on file for the payment. And then there's also a one-time $150 engagement fee paid to providers using the specific code G012. Does not require a modifier, and it will require a TAR. This amount is also used to help cover unsuccessful engagement attempts. So I'll go ahead and pass it over to Deb, and I'll make sure we provide the link to the codes in the chat. Thank you.
Sorry, I was on mute. Hi, everyone. So for community supports, there weren't too many changes to the original codes that were put out. The pricing did not change, which I know is one thing everybody is always wondering about. We are still going with the mid-range, and the additional things were about non-skilled respite and skilled respite. And then the other piece is self-directed virtual housing navigation.
Thank you so much, Debbie. So I did want to let everyone know that the links that were just discussed for DHCA coding guidance updates were provided in the chat. And I also wanted to distinguish that Danielle spoke about updates pertaining to ECM specifically, and Debbie referenced the information pertaining to CS specifically. And once again, if you have questions about that information, we are going to have a Q&A section in just a few moments. Next slide, please. All right, so now we are going to hear about key budgeting and payment considerations from the CEO and founder of HealthBegins, Rishi.
Thank you, Alexis, and thanks everybody, especially a big thanks to our colleagues and friends from Partnership Health Plan of California and to all of you joining in today. So let me just take a moment here to pull up the screen where you guys are at, because when I clicked in to kind of see you, I lost the view of the other screen. There you are. Okay, thank you. So we wanted to just underscore what I think Lisa had first teed up in terms of some of the core components we know for plans across the state, including for Partnership Health Plan. One of the core elements of becoming a credentialed provider is to have an NPI. And just if you can, for CBOs that are on the line today, if you would mind taking a moment just to put in the chat and let us know if those who are already aware of the NPI process, or if you already have one, please let us know. But if you also let us know if you haven't yet received or applied for an organizational NPI. So feel free to share anything you can about just where you're at in terms of the NPI process. And I'll take a moment as you do that to review some of the basics. An NPI is a 10-digit number assigned by the Centers for Medicare and Medicaid Services, CMS. It's used for electronic claims transaction for healthcare billing and reimbursement. NPIs are required for all ECM and community support providers, including non-traditional providers, to receive payment. Obviously, that's applicable here for CBOs. And thank you for those who are sharing that information in the chat. It sounds like some of you already have them. And of course, on the county side, may have multiple ones. There are different ways to apply for an NPI, and some of the resources that you'll see in the deck that you received this information, as well as what I think we can recap during the Q&A, is resources that Partnership itself has actually suggested for a step-by-step guide to apply for an NPI. In summary, though, the steps are to apply online or by mail for free. The time it takes to process and receive your NPI will differ based on whether you do online or by mail. And your NPIs can be applied for either as an individual or as an organization. As is the case for some of you, if you already have an NPI, you don't need to submit a new application, but it's important to be able to check, in this case with Partnership or whatever managed care plan you're working with, to make sure that the NPI you have is reflective of the services that you plan to provide through community supports. We go to the next slide, please. Taxonomy codes is a big element of this, and I think this is where there's been some updates. So I think I'll put into the chat the updated guidance. For example, around coding that was referred to just a moment ago, and I think Danielle had shared it as well just a few moments ago. So this is important because what you see on the screen is reflective of what DHCS had initially put out in terms of guidance on the suggested and recommended taxonomy codes for ECM services, and more relevant here, community supports. They developed this guidance to help inform provider decision-making, but it's the responsibility of any provider, in this case, community support providers, to select the appropriate taxonomy code, the code that is most accurate and reflective of the services you'll be providing. If you're, again, applying for this process, or you want to make sure that your current NPI, if you already have one, is consistent, it's important to kind of both check with the updated guidance that you see in the link provided in the chat. And also, of course, just review that if you have questions with Partnership Health Plan, all of whom are here today. If you go to the next slide, this is the initial suggested taxonomy codes from DHCS in their first kind of guidance. But you'll see that I think, was it Deb who had mentioned that some of these, there's been some minor tweaks to this, and that's important to look at. If you click on the links in the chat, you'll see pages, I believe, starting at page 4 or 5 in the updated guidance, in the link, you'll see that there's some slight modifications to some of the codes, the HCFS codes that are in there, but the taxonomy code for NPI at least is what you see here on the screen. I'll pause here and see if there's any updates from partnership, in particular about the taxonomy codes for NPI that you want to clarify here based on the initial guidance DHCS has suggested. When it comes to the taxonomy codes, at least for the NPI process. Any comments, Lisa or Deb or anybody from or Danielle, when it comes to the taxonomy codes?
None from me. I don't know if Danielle has anything.
Okay.
No, I don't. Thank you.
Great. Let's go to the next slide, and then I think we're going to go open it up to Q&A for everybody so we can hear from you. I think one big question, of course, that many of you are all actively discussing or probably interested in, of course, is the payment kind of system. DHCS had provided non-binding pricing guidance, and you see it. Thanks, Nas, for putting in the chat. This is pricing guidance that was made available to managed care plans to support discussions regarding community support rates. It's important to note, and I think this is something that you'll probably hear again today if you haven't heard it already, that plans are not receiving additional funds for community supports. There are incentive dollars that are coming in later on to support the alignment of some of the work under CalAIM with performance measures. But for the community supports in general, there's no additional funds received. They're meant by definition to be medically appropriate as well as cost-effective alternatives to state plan services. And the associated funding that plans are receiving are built into the capitation payments that they're getting. Plans will pay contracted community support providers for the provision of services based on the rates that you negotiate with them. And I think, as Lisa, you mentioned that there's already a contract that's a core step in this. And so I'll give you the baton in a moment to kind of just underscore that point about the rates in the contract that you have and that you're requesting all CBOs to be able to review. But a key thing as you go to the next slide here for payments is that when you look at the DHCS pricing guidance, and as you're considering your own work, as many of you I'm sure are already considering, it's important to note that DHCS itself took a step of dividing the pre-approved community supports, those 14 community supports, formerly called in lieu of services. They had taken those in lieu of services or community supports and divided them into 3 major types based on the differences in approaches to establishing rates, and they essentially based on different payment approaches that could be taken. Bundled payments, as you see here, fee-for-service payments, for example, for a unit of time or per meal, and then a cost-based reimbursement approach up to a certain cap. And so it can be helpful, the DHCS pricing guidance can still be really helpful as you're in conversations with plan partners, whether it's here in Shasta and Sonoma with Partnership Health Plan, or if you're working in other counties with other partners as well, with other plan partners, to be able to review the DHCS pricing guidance is a very informative document if you haven't had a chance to review it. Again, the link is in the chat and Nasser has shared that. Next slide. In the pricing guidance, you'll see examples of some of the assumptions that that DHCS had researched and included to be able to calculate what you see here is called the midpoint service rate. You'll also find a description, as you can see on the top left here, of the high-level pricing approach for each of the community support services as well. So this document, again, is very rich, and here's just one example of the ways in which you can see the different assumptions about the midpoint service rates, the rate ranges. You can see even on in the table on the right, the various assumptions on cost drivers that DHCS has listed in this pricing guidance and how they impact different assumptions. So for example, you see assumptions about cost drivers regarding staffing ratios for housing transition navigation services, where it says here, the assumption was for staffing ratios that there's 1 housing care manager for 20 to 50 enrollees or 1 supervisor to 10 housing care managers. It's clear that not all CBOs operate from the same assumptions. And so if you have different assumptions regarding your staffing ratios or caseload or other cost drivers as listed here, it's important to be able to use this pricing guidance from our experience in talking to CBOs to use this guidance to be able to then consider what your own needs are and then to enter into those conversations, obviously with your plans, better informed about your cost driver assumptions. So if you go to the next slide here, we can always come back to this. And the main thing I wanted to do is to tee this up now for our friends from Partnership and for all of you to be able to ask each other questions. But this is a quick point on the incentive payments that I mentioned earlier. And that is that incentive payments that will be coming through will be directed to plans. DHCS is encouraging plans to partner and share the incentive dollars with providers who help to achieve defined targets of the incentive program, namely targets meeting quality and performance improvement measures. But with that, without further ado here, let's go to the next slide here. And I think I'll turn it back to Alexis so we can facilitate the Q&A.
Thank you so much, Rishi. So we did want to open up the floor for a Q&A. And just to back up for just a moment, I did want to remind everyone again that the link to this entire document has been posted in the chat, so that way you can follow along with all of the information that's being provided. And based on the credentialing information, the updated coding guidance, and information on budgeting considerations, we wanted to open it up to ask the CBOs to participate in a Q&A to see what additional information you may need or questions that you may have for a partnership health plan. And additionally, if there are any CBOs that wanted to back up to the polling question that we originally asked, we did have a number of individuals that posted in the chat that one of the concerns they had was surrounding data sharing challenges pertaining to infrastructure, training of staff, and reviewing of existing systems. Did anyone want to go ahead and highlight any of their concerns pertaining to that specifically?
Alexis, maybe if I can just say, it looks like some folks are coming online as we hear from our CBOs. I'll also invite our friends from Partnership Health Plan as well to chime in if you're coming across similar questions about data sharing or any other infrastructure kind of questions in your conversations with other CBOs, potential community support providers, to please share with us what you're hearing and what kind of advice you give. But it looks like I saw Donnell come off mute, so welcome.
Yes, thank you. I'm Donnell Ewer. I'm the Director of Health and Human Services in Shasta County. We have a question about the housing transition navigation, which apparently we only can claim for 90 days of continuous duration. And I guess our concern there is that, the type of people we've been working with in whole person care, we know from experience that we do not resolve their problems in 90 days. And we got to pay the bills, for paying our employees. So how are we supposed to think about that as far as claiming for the time that our people are going to be spending on these cases?
This is Debbie, and that is a concern of everybody who we have been in contact with and those that we have not yet been in contact with. So know that 90 days is a starting line. It's a base, your base, if you will. There may be one or two people who actually you can get taken care of in 90 days, but chances are the majority of people will take a significant amount of time longer than that. So what you would do is get a TAR for the 3 months, and then you would ask for a continuation or for an extension. So we will make those readily available. We totally are aware of the constraints. This is really new to all of us. DHCS has given us guidelines about a lot of things, but we're learning as we go. And we're very thankful for the CBOs who are sharing with us their concerns, because we take those back to DHCS and know that we are all in it together. And I know our member population, and 90 days is a drop in the hat. And I totally realize that, and we will work together on it.
Thank you. And Alexis, I see a great question from Laura and then Lisa's response. So if we want to voice that over, thank you.
Perfect. Yeah. So Lisa, we do see that you responded to Laura in the chat. Would you mind elaborating on that for us? And at the same time that Lisa is going ahead to do that, we did want to let everyone know that we have a very brief 3-minute survey that's in the chat right now, just to make sure that we can continue to bring you the information, resources, and knowledge that you all need to be successful. So at the same time that we're discussing the next question, you guys can also take a moment just to complete that brief survey.
Hi, so Laura asked, saying that they don't fall into the current categories. They have BA level case managers that would not be credentialed, which is correct. But does that mean we're not able to participate as community supports? No, that does not mean that. That just means that we don't credential that provider because there's no pathway. But that does not mean that you couldn't participate, or that they couldn't participate as a provider if you are a CS provider.
So, and all CS providers will have to be contracted through the non-provider contracting. So the contract gets you a number gets you a TAR availability, and then you get paid.
Thank you so much. And so as we are continuing to encourage the CBOs to take this opportunity to ask the questions that you have, once again, we do have that survey that is in the chat for you, but I would also like to take a moment because we have one of our partners, Lisa from Transform Health on the line. Lisa, I definitely just wanted to give you the mic for a moment to see if there's any information you wanted to additionally contribute to this Q&A session.
Oh, I was just going to say some of the experiences that we ran into. I'm currently running the City of Sacramento's whole person care pilot, dealing with similar populations. And we completed our evaluation. And one of the things we learned is for the sickest amongst the homeless, it took 6 to 9 months in our whole person care pilot for them to really stabilize and see the benefit of these services. We're happy to share that evaluation report for anybody who's interested in it. But I wanted to flag that it does become a range. And so we've had the experience where folks have come on to our program, have been on maybe 3 months, 6 months, and fallen off, and then have had to get reauthorized. So if I could offer any advice here, I think it's reasonable and important for providers to stay engaged with their plan partners, and partnership is a fantastic plan to be working with and very supportive of local implementation. So raising these issues and surfacing it and asking for additional 90 days, that's happened a lot in the whole person care pilots and is certainly something that can be done under the new program. So I would encourage everybody to think about, just because you're only authorized for a certain time period, it's always okay to go back and say, hey, this person needs something additional, or we need 2 extra months, and get authorized for additional time. Thank you.
Thank you so much, Lisa. And to build upon that, we definitely like to make sure that, CBOs can still ask questions. We do have everyone and all of these resources available to you to answer questions in real time that they do currently have information or responses to. So yeah, we can definitely take a few more moments. You can use the chat. You can feel free to unmute. And we can also welcome partnership to add upon Lisa's last comments to see if there's anything that anyone else has to add upon that. And Nasser, we can stop screen sharing for just a moment as well.
Alexis, sorry, go ahead now.
I have another question after you guys comment.
I was just going to comment on the previous request about data sharing. We have noticed that in particular, as we're working through contracting with our community supports providers, there's a lot of questions about the necessity for data sharing agreements and a draft BAA, which is included in our contract. For the purposes of partnership and sharing data, we find those necessary, especially for the reporting requirements that DHCS has for this program. So we have gotten a lot of questions, and kind of echoing what the provider shared in the survey. We understand that there's a lot of back and forth and questions, but this is standard when it comes to working in the Medi-Cal program, because we will be sharing personal information back and forth about members receiving the benefit, but also potential members who may not be receiving the benefit. So we need to make sure that we've kind of dotted our I's and crossed all of our T's when it comes to data sharing. But I just wanted to follow up, Alexis, on that. And we know that's an issue, and we've had a lot of back and forth with interested providers.
All right,
So,
thank you so much, Amy. Oh, sorry, Donnell.
That's okay. It's hard to just know when someone wants to speak in these kinds of rooms. So we've been working very long and hard in our county with our continuum of care on coordinated entry, and we have a whole system that we've developed over. It took us a very long time, but we use the VS-SPDAT screening tool, and the folks who are homeless are prioritized based on their need and so forth. And our housing case managers have caseloads, and we're trying to honor that. We meet with other organizations in the community that do case management, and they try to coordinate who they're working with, working with those highest priority people based on those screenings. And so I guess we're trying to figure out how this will all work if, based on this medical necessity thing you guys have, it seems like it's going around coordinated entry. And so we're just trying to figure out how that would all interface. If we had, say, 3 case managers or 4 case managers, and we had a cap, on the number of people, and then you referred somebody to us, but they're not the highest priority in coordinated entry, it creates a bit of a quandary for us. And I'm just wondering if you had put any thought into that, or how, if anyone else has raised this issue, or if you have ideas of how we might resolve it.
So Janelle, just to I know it's called, is it the question about the members we would refer, partnership members, in line with all the other issues around housing and the funding, and like grading the funding to make sure that costs are covered, or just making sure that the members are appropriately served in order based on priority?
Well, we have a lot of different funding streams to work with the homeless, and we try to braid that. I guess the question, a more direct question is it your thinking that we need to dedicate certain people for this caseload, for the partnership health plan benefit people, and they're not participating in coordinated entry, or, and that, our other people would have to work with the list that's created through those community screenings and so forth? Or is there a way to dovetail it? Because we are trying to create a single system for assisting these people, and we do try to braid these different funding streams and so forth. And I guess in our minds, this new benefit through Medi-Cal is going to be part of that braiding, but it seems like if we've got to just take referrals straight from you and serve them ASAP, that kind of takes it out of the coordinated entry realm. And so we're just trying to understand kind of what you all envision with that.
This is Debbie, and I coordinated entry is very important to us, and we aren't just going to arbitrarily assigning things. We want to know when you're at capacity. We want to know when it's not working. We want to know if our referrals are not coming through coordinated entry or are not working for you. So it has to be a collaborative. So I guess our vision is that we're going to be working closely with any of our providers to make sure that we're not upsetting the apple cart.
Would it be possible for someone from partnership to attend the community meetings? And Laura McDuffie would have to comment on how, when those are and how frequently they are, in order to collaborate and coordinate that, because the federally qualified health centers are other partners with us, in those meetings, and there may be 1 or 2 other organizations. So, ideally, everyone would get on board, right, with this Medi-Cal benefit, and everyone would be doing that as well as other, having the other funding streams. And so it just seems kind of central, but I'll let Laura comment on how that works, because she knows the nitty gritty a little better than me.
I think, hi, I thank you for addressing this issue. I think, I guess our question, it does question how we dovetail it. I think we're wondering, I know that in our view that the referrals will come from partnership to the provider. Our question is, can they come back the other direction? Because
Yes.
we have our coordinated entry list in front of us, knowing who's most appropriate. So can we take that list and refer them back up instead of the other way around? I think that would then at least help us with our coordinated entry piece that we're supposed to do.
So there's no wrong door, which means that you refer to us, we refer to you, PCPs refer, CBOs that get a referral, contact us, get a TAR. So there's no wrong door. And so that's how we will be collaborating, is making sure that we share the wealth, making sure that people are getting the information on the referral that they need and in a timely fashion and all of that.
I think, and this is what will happen across the state too, is that we are required to serve those who have a score of whatever, 8 or higher. So if you're sending us somebody who's got a score of 3 or 4, we shouldn't be serving them with our funding, with our other housing funding that we have. So would we be allowed not to kind of prioritize them that way based on the coordinated entry scores? Or are you thinking first come, first serve as you refer them out?
No, I think it has to do with who needs the services the most intensely, or I mean, we want everybody to get service, but certainly there's going to be more that are in need right now than someone who can wait a week or 2 weeks.
Okay. It may be something that we just need to continue to work on, and maybe it'll make sense as we just start doing it.
Yeah.
I don't know.
I don't know 100% either, but our vision is collaboration and making sure that it flows for all the providers, and so that the members get cared for in a timely fashion. But certainly those that are the most critical, the ones that need the most, should certainly be sort of in the top of the mart.
And this is Danielle. I would agree with that. Also, that's why the reporting requirements and reporting the ECM members is really critical, because there will be opportunity for the providers to identify ECM members that we may not be aware of. And so reporting that back to us is really essential. So it like Debbie said, there's no wrong door. And so that's a way to communicate with us that a member did receive ECM, they did enroll in the benefit through the reporting, but you can also call us too. We're going to have several different ways for providers to submit referrals should that need to happen too. But I think in this case, the reporting would be the best bet to notify PHC that way.
This is Lisa with Transform Health. If I can just offer a perspective, this type of conversation is happening statewide between plans and counties on a number of levels. And I think you guys are absolutely right. Additional conversations, coordination, working through this is going to be important, and allowing for time for that will be important as well. A couple of things for you guys to consider. The ECM community supports criteria are really intended to reach those of high acuity and high level of health need. Whereas on the continuum of care side, you're prioritizing, based on need, but on a slightly different scale. So it might be worthwhile to have some localized conversations between your local continuum of care or housing authorities together to figure out how you might want to dovetail those two experiences and those two assessments, because I think you're going to end up finding that a lot of the folks who rank high on the VI-SPDAT are going to end up ranking high and fall into the ECM and CS categories and be eligible for those supports. A couple of things that we've done here in Sacramento County was really to work with the city and the county to work with the local continuum of care and allocate a portion of HCV vouchers to our whole person care pilot, understanding and linking back to the high level of needs and aligning it back with VI-SPDAT. That is one potential approach. The other approach is to really work through and think through, like, as ECM and CS providers connect in with the continuum of care, training them on the VI-SPDAT and how the COC thinks of prioritization. And that would be helpful too, because the way ECM and CS is structured, the housing navigation you could be navigating beneficiaries, patients into public programs. It could be permanent supportive housing, it could be a voucher, it could be like a local shelter, or room key if it's still available. And so there's ongoing conversations that is needed and relationship building that is needed between plans and local COCs regardless, because the alignment between those two worlds and those programs is really more of an annual regular activity.
Right.
Thank you.
Thank you so much, Lisa, for all of that information. And I did want to note that we have a comment in the chat right now that says, I've heard of some teams that are creating a subpopulation of focus from those who are community supports referrals, but also coordinated entry. Katie, would you mind elaborating, or anyone from partnership, or Lisa yourself, would anybody mind providing feedback on that?
So this is Katie. This was just came up in a conversation that I'd had with some of my counterparts from other counties, and they were also kind of trying to navigate the intersection of the medical model with the housing first model is really what it came down to for them. And so how were they kind of tossing it around like, okay, so how do we take the referrals for our homeless or at risk of homelessness population and still keep a focus to housing first principles and models? How do we marry the two? And then one of their first concepts was to kind of put an additional identifier on people who are already in their coordinated entry process and might be showing up as those referrals. So that was my understanding of the first approach they were going to try. Kind of a dual identification, I guess.
Deb, for us, could we flag that on the TAR when we get the referral that they're connected to coordinated entry? Could that be a flag?
I think that was something that the provider had to send back up to their managed care plan.
Oh, after, I don't know.
They would get the referral from the managed care plan, and the managed care plan may not have any idea that they were on a coordinated entry list or where they would be in that process.
So that goes to it. I'm sorry, Katie. I just want to clarify. So there's two ways, either through you referring people on your coordinated entry list to partnership could flag that they're through your coordinated entry program. But your question is, once we refer them to you, how do you flag back to us? They're already a part of coordinated entry or connected to the program?
Yeah, it would be, so the people I was talking to were first thinking that they would be catching referrals, and then they would just kind of work out their system internally to figure out, okay, so they're already in coordinated entry, or we need to get them into coordinated entry. So they'd be sorting through that process. But then eventually they would want to say, hey, this person seems, once they have a better idea of how the referral system works, they would be able to identify people who were already on their coordinated entry list who they don't have a community supports referral for, and flag that back to you.
Sure.
Yeah.
I want to just interject and build on that and say that, Katie, I think what you're raising really nicely, and it sounds like Debbie and Amy, you're mentioning that it sounds like there's three benefits already of talking about the flagging system, right? There's benefits to partnership, there's benefits to the community support provider, and if the community support provider itself is also doing coordinated entry, then for the teams who are doing coordinated entry to also know. So there's multiple flags, and I just want to anchor that back to Lisa. What you mentioned is a really great point here, and say that as the COC and the housing agency kind of comes together and says, how does our assessment process align with the assessment criteria for ECM and community supports? It also sounds like that's an opportunity to not only align on the assessment criteria and the scoring and severity kind of criteria, but also then the tracking systems, right? And feels like, Katie, your point there feels like a good example of exactly that. Does that make sense?
Yeah.
Absolutely, Rishi. I think that's a point that can't be made like enough, that it takes a lot of conversations and a lot of coordination, because we're aligning to separate industries that really haven't been aligned before. And so many under many whole person care pilots, and Katie, you're probably aware of this already, given that your work in Shasta, there had to be a lot of realignment conversations, and also even just definitional conversations. I mean, one of the things that was fascinating as we were launching in Sacramento, we realized that our clinical providers and our housing providers were all using the term, for example, case management, but meaning something completely different on the ground with different outputs and different goals. And so unpacking some of that and building some of the flags into the on the housing side with HMIS versus the healthcare side in any of your case management software, or how you track things, or in data systems. I see Redwood Coalition for Healthy California is on. And so, thinking about the EHRs and how do you create those flags for the ECM and CS providers will require local conversations. I also wanted to share with folks, I've also heard, a number of counties are, and the plans are also talking about, well, does set asides around vouchers make sense for some of this population, or do you just rely mainly on current standing approaches for assessing and evaluating based on acuity levels? So that's an important conversation to also begin thinking through. And, you know, in some communities, we're also seeing housing providers and the counties are folks funding housing programs, taking a look at ECM and CS and saying, you know, amongst our populations, this model will work well. And then there are some who will fall through the cracks. And amongst the, like, for example, we've heard in Sacramento, like the sickest and the most chronically ill amongst the homeless, who are also chronically homeless for like multiple years at a time, they have a tendency to fall off in the programming unless they have a champion help guide them through. Yeah, so there are conversations locally, given our experience, that maybe there is a portion of and rethinking like a slightly different model for really the most acute and the sickest, and whether there are value to doing like a Brilliant Corners model in that world, in that vein. So I do think, you know, one of the challenges in front of counties is, do you want to rethink your housing programs and aligning it with the ECMCS needs and finding ways to sort of dovetail the two?
Yeah, Lisa, if I may, and Alexis, I'm also just looking at the time and thinking that before I invite, and Alexis, if it's okay with you also to build on Lisa's point, folks from Redwood and Mariana and Dana from Sonoma as well. I think we've heard really great, really rich kind of conversation with Shasta. Just want to make sure we have space for others who haven't had a chance to ask questions to go. But at least a really quick kind of just really quick build onto that is it brings up this idea of how to create collaborative case reviews between ECM and CS providers and coordinated entry kind of teams in those areas, especially for those folks at the top of the risk pyramid, if you will, as well. And the question then becomes, how does that to be able to facilitate not just alignment on assessment criteria, alignment on tracking and data kind of systems, but then alignment also on case management. There's local conversations, I think, is the key takeaway that I'm hearing. But yeah, Alexis, if it's okay, I just wanted to see if there's anybody else who hasn't had a chance to chime in to do that.
Most definitely.
I see Mariana, Beth, Dana. And there's iPhone 707-295-9595. Welcome as well. Anybody, and Des from Sonoma. Okay.
I mean, perhaps the information sharing was rich enough that all of their questions were answered. But we do want to thank our partners and Partnership Health Plan and everyone that contributed to the Q&A. Once again, I did want to remind everyone that we are attaching a PDF that has a link to all of the resources and information that was found inside of this session, inside of the chat right now. And Nasser, we can actually go ahead and start screen sharing again. And let's give that just a moment. Perfect. Next slide. And next slide. Perfect. So for anyone that does think of any questions that may not have been posed today, definitely feel free to email us at info@healthbegins.org. I'm so sorry to be the broken record, but all of the individuals that participated today and contributed to the session's information and dialogue, you know, re-emphasize that the links that were discussed throughout this session are critically important. They are not passive links. They're very important, and they will support you in the credentialing and contracting process. So once again, that link is there, and I'll make sure to email that out to everyone after this session as well. As previously noted, we did include an evaluation survey inside of the chat as well, so that way we can know what information you need to receive in the future that might also help you in navigating the system and navigating this process. And lastly, we do have an upcoming session that will take place next Thursday on the 16th. It is a statewide session. There's an open invitation, and I'm pretty sure that everyone that is here with us today received that information and the link to that webinar. And we are going to be discussing different content. So you know that we will have additional information that will support this process as well. Next slide. And lastly, we would like to give a wonderful thank you to the project team that includes Sadna, Nasira, and Rishi here at HealthBegins, Jill and Lucy from Aurrera, Carlina Hansen, our funder from CHCF, and our implementation partners that are on the line from Transform Health, Alex Fajardo, Beth Siegel, and Devin Winey. We would definitely like to appreciate you and all of the information that was contributed to creating this slide deck and bringing this session to life. And we'd also like to give a huge thank you to all of our presenters from Partnership Healthcare. Next slide. And that is all for today. Once again, please feel free to email us, review that slide deck, ask questions that you may have. And we once again included the contact information for a partnership health plan inside of that slide deck and inside of the chat, so that way you could have access to them as well. Thank you once again for joining us for the second TA session in Sonoma and Shasta. And that's all that we have for today. Thank you all and have a good afternoon.